in Hamilton, and I'm very proud looking at your brochure that McMaster University has a logo here. This is the smallest logo, but it's quite important and we are quite proud of being part of this. And Professor Ducatis is my colleague next door, effectively. So my goal today is to talk to you about sepsis, what's new, what's old, what's crucial to know. My conflict of interest is unfortunately completely empty, unfortunately for the reasons you may want to interpret. My learning objectives for today is to recognize the recent changes in sepsis management. What I would like to accomplish is to introduce a concept of differentiation between strong and weak recommendations, i.e. something what should be done versus something what could be done, and remember priorities. Preparing those presentations, speakers usually want the audience to leave with one or two important messages which they would remember, and I will try to point to you when those messages will come. The topic is not only of academic interest to me, but also of historical interest, because I deal with the topics of sepsis for about the last 30 years, and I was part of something called Surviving Sepsis campaign for a number of years. The most recent reiteration came in 2022, effectively, and I highlighted a number of names coming from my institution, from McMaster University, and I had privilege to have them all as fellows and learners under my care. So the topic is personal. What I would like to talk to you about is a number of clinical areas, including screening, dealing with infection, dealing with fluid and hemodynamic management, and additional therapies. Sepsis is usually something what we see in intensive care unit with catheters, with arterial lines, with liters of fluid, with these days ECMO machines and dialysis machine. And one of my main concepts which I would like to sell to you is that this is the end of sepsis. The sepsis starts much earlier, starts with us, with internists, not necessarily in intensive care unit 24 hours later. The first evolution and revolution in sepsis was change of the description, of the definition of the concept. It became a description of pathophysiology. It was recognition that what harms the patient and what makes the clinical picture is not necessarily the organisms which attacks us, but it's the response of the body to such attack in a dysregulated way. So 2016 definition said that sepsis is essentially presumed infection, and it's difficult to decide what it is really, but once we see one, we probably know what it means. And deterioration in functional score, in a score of function of different organs, being it liver, lung, blood pressure, central nervous system, or kidneys. And then there is a progression to septic shock once this is associated with need for pressors and for elevation of lactic acid. This by itself is important. I still remember 20 years ago, we couldn't get lactic acid measurement. 15 years ago, I had to send it to another hospital. 10 years ago, I had to wake up biochemist. 5 years ago, we could measure it on the bedside. The SOFA score is something what haunts a lot of people who hear about it because it's difficult to remember. Effectively, it talks about different systems, so lungs, platelets, bilirubin, hypotension, Glasgow Coma Scale, creatinine on decreased urine output, and it has a table which is impossible to remember and practically used. So the usefulness on it is frequently in the research studies. If we have this sepsis plus deterioration in this score by 2 points, we defined it as sepsis in this new system. Septic shock, as I mentioned, requires two components. One is resuscitation with fluids and still hypotension, which means you are effectively on pressors. and elevation of lactate. Now, I would like to introduce a concept which will keep coming during my presentation. This is concept of strong recommendations versus weak recommendations. Weak recommendations which are also used suggestions. This is differentiations between what we know and what we should do versus what we believe we should do because we believe that the balance is in favor, but are not quite clear on that, as in the case in strong recommendations. The operational definition here is that if you do not do something, if you do not give antibiotic for a person suspected of bacterial infection, you better have a good explanation why not. Weak recommendation, if you believe that something could be done, but your resident or your student even says, no, I don't think that's true, you shouldn't get too upset. You shouldn't be too dogmatic because the evidence is equivocal. The other thing which you will see is the symbols assigned to different recommendations. This means please do it, don't do it under any circumstances. And there is a quality of evidence because sometimes we know the effect of certain action very well. We call it high quality evidence. Sometimes we don't have much clue because it's coming from individual patients' observations only, for example. Also, in practice guidelines to which we are exposed, about which Professor Ducatis was talking, we have different layers on those practice guidelines. Sometimes they will tell us, you know, you give protein concentrate in this situation. Sometimes they will explain a little bit more, and sometimes they will present the systemic reviews. Depending on how deeply you want to dig into it, most physicians, I would say 90%, are interested only in final recommendation. Some, especially teachers or especially clinical practice guidelines developers, should dig quite a bit lower. So let's go to specific clinical areas of management. I will start from screening and early treatment, and I will go again historically to some degree. I mentioned to you that the SOFA system is almost not something what regular mortal person could remember. So the authors of these concepts came with something called quick SOFA, which means you look at the certain things which are frequently associated with sepsis, and these are hypotension, altered mental status, and tachypnea. And if you have 2 out of 3 here, you are suspected of sepsis. Now, you could imagine, and I will not ask any tricky question, but if you are hypotensive, confused, and tachypnic, are you a little sick or are you really sick by now? Who thinks you are, a little sick? Hand up. Who thinks you are really sick by now? Okay, so it's very clear that this is an advanced stage of sepsis. We are probably familiar with something called SIRS, Systemic Inflammatory Response Syndrome, which was you breathe faster, your heart rate beats, your temperature is 38, and your white blood cell is elevated. And you have now the quick SOFA. As you could see here, you could be sick a little bit. Here, you have to be sick a lot. In other words, if you try to use it as a screening test, you will miss a lot of early stages here, because this will occur quite a bit earlier than this. The bottom line, the Surviving Sepsis campaign said, even though authors of this original definition of sepsis recommended using QSOFA as a screening test, they recommend against using it because essentially it will miss a lot of early stages. On the other hand, they suggest measuring blood lactate, which is really required for the diagnosis of septic shock, so it will give you a fairly good idea of how advanced the process is. Lactic acid probably will not be elevated in people with SIRS, may be elevated with people who have QSOFA. Now, we asked 821 people, intensivists, what they used once they were exposed to those concepts. And about this part said, oh, we are using this Q-SOFA or SOFA deterioration. These people said, we are using SIRS, SOFA, or we are using clinical judgment. As you could see, the evidence and what we are recommended doesn't dictate the actual clinical decision. How to monitor the response of treatment? This is really the story of last 20 years. It started in 2001 with a paper which is commonly referred to as RIVERS, in which people with severe sepsis or septic shock were subjected to usual care, and I want to stress usual care at 2001, versus something called early goal-directed therapy. Relatively complex, but in reality simple. You have a patient who is septic, who is now on oxygen, getting fluid, is getting fluid to the point that they are full, and fullness is assessed by using central venous pressure. Once you have them full, you are looking at blood pressure. If the blood pressure is low despite receiving fluids, you start vasoactive agent. Used to be dopamine, these days it's norepinephrine. And if they are still showing sign of hypoperfusion, you try to give them blood, and you are using inotropic agents like dobutamine. The way how hypoperfusion was assessed was with the use of the central venous catheter, which was sampling blood. And the idea was that if this blood from the central was deoxygenated, it was saying the body is screaming for more oxygen, more delivery, i.e. you are still having situation of hypoperfusion. This was a revolution. We moved here after this study, for example, from giving 250 to 500 cc's bolus of fluid for septic people, we moved to 2 or 3 liters because in this study, the group which benefited from it received 5 liters of fluid over 6-hour period. So it really was a revolution in the making, and I again say this is beginning of 2000s. Now, the first challenge for it came in 2010 when somebody said, okay, could we do the same as the RIVERS was doing, which is this part, fluid, pressors, blood transfusion, and monitoring it using the oxygenation of central blood. Could we do the same but measure what we are doing or assess the effectiveness of what we are doing using lactate clearance? So every 2 hours they were measuring lactate, and if the lactate was coming down, we are doing well. If the lactate was not coming down, we are not doing that well, and we should continue. Now, the number of studies were done, and effectively the lactate goals were better than the central venous oxygenation goals, which was a great relief for us, because suddenly we didn't need to put the specific catheters in the middle of the night and drawing blood. We were doing simple blood tests. So this was a relief. We moved in this direction. And in 2014, there was another challenge to RIVERS protocol, which were 3 consecutive papers published in 1 issue of New England Journal, which effectively, they were called Process, Arise, and Promise. And they all showed that comparing what they called standard care versus RIVERS protocol, there was no difference. Now, this was part of the same protocol, the usual care, which was again saying you give fluid, you give pressors, you give hypoperfusion. And now comes the first thing which I would like you to remember, which is here. They were reassessing these patients every 30 minutes. There was an experienced person who knew the RIVERS study, who knew the measurement of lactate, who was looking after the patient every 30 minutes. I will come back to this a little later. It was their standard care, not the RIVERS protocol, but standard care. They tried to avoid central line. They were careful in terms of fluid repletion and looking for overload. And they say that hypoperfusion was defined as clinical diagnosis by the treating experienced physician. They could use things like hypotension, elevation of lactate, mottled skin, oliguria, or altered sensorium. My impression is that this is the most important part. They had experienced person who knew lactate, who knew by that time a little bit of the ultrasound volume assessment, who knew results of river studies, who was seeing this patient every 30 minutes. Well, we went from oximetric swan, as it used to be called, to lactic acid. There was something yet which came, I believe, in 2019 now in our journey, where people compared lactic acid clearance with capillary refill time. And again, every 30 minutes. What does it mean? Every 30 minutes, somebody was coming to the patient, squeezing either toes or fingers, and looking at capillary refill time, and using that as a evidence of hypoperfusion. Again, the 30 minutes come back. What they found is, and I want to remind you, we moved from sophisticated catheter, measuring continuously oxygenation, through lactic acid, which required lab every 2 hours, now to compressing the fingernails. What they found that this new method, perfusion group, had mortality which was about 8% lower, which the ones which at that time was considered to be the best, which is lactate driven. Now, how to square it? We are doing less and less, and we are improving more and more. Somehow doesn't fit to how the world seems to operate. My own impression after this 30 years trip is that we don't need these oximetric swans. We don't need to measure central venous oxygenation. We can minimize transfusion. We can use less dobutamine, but we need to assess patients frequently, and we can use different clinical assessment of volume status to guide therapy, including lactate level and capillary refill time. Accordingly, the Surviving Sepsis campaign suggests now that we use lactic acid to measure efficacy of resuscitation, and it suggests that we use capillary refill time, which is a big relief to all of us who do not necessarily have access to this sophisticated machinery. Lastly, how much fluid? Because that's another revolution. In 2016, the standard was 30 milliliters per kilogram over the first 3 hours. So in some countries, it would be 2 liters. In some countries, like North America, it would be easily 3 liters on average. It changes. It went from we recommend to we suggest. Nevertheless, the suggestion was still to use quite a bit of fluid. We asked again people, how do they resuscitate fluid? Is it 30 mils per 3 hours, or is it bolus of 500 or a liter? And these were the answers. We had probably 600 answers from around the floor. And as you could see, roughly half would go with without much thinking, and about half would say 50 to 100,000 milliliters with reassessment. So again, the evidence or even the recommendations are not making decisions for us. The most recent one, February of 2023, went a little bit farther. It again looked at liberal versus restrictive, and liberal fluids were 2 liters of crystalloids to start and then boluses, versus restrictive, which is no boluses, but use things if there is sign of hypovolemia. And it's again worthwhile, this is the other thing which I want you to remember, that even though it was restrictive, in a patient who was hypotensive or even hypotensive despite pressures, or who had high lactate, or who was tachycardic, or you had hemodynamic evidence of hypovolemia on echo or bedside ultrasound, the rescue fluid should be and may be administered at the discretion. I would argue that this rescue fluid, if the patients had none of them, there was no business to give them fluid. These people got 2 liters of crystalloids to start, and long behold, The mortality was very similar. It actually should be here 14.9, not 14.0. So slightly elevated, slightly elevated in the liberal fluids, but was essentially the same. And the difference in fluid amount was exactly this of 2 liters given as a start at the bolus. So the summary. How to reconcile what we do? Does it matter what we do? Because some people interpreted it as, well, it doesn't matter what you do. Put a swan, put a catheter, you measure lactate, doesn't matter. No, it does. All these people who were in all those studies were experienced people. All patients were reassessed every 30 to 60 seconds. This is the one message which I want to tell you. Probably nothing matters as much as seeing these people frequently. Hypoperfusion and hypotension was repeatedly assessed. And how you monitor probably doesn't matter. Oxygenation, lactate, capillary refill time. Use what's available to you and stay on the bedside. And yes, it matters what we do. This would be the last slide which I want to show you, which is time. Time is the second thing which I want you to remember. This slide talks about the control of the source. If you do it within 6 hours, your odds of dying are here. If you don't do it for 24 hours, they about triple. So that's number one. Even more importantly, if you delay antimicrobials, you go less than 3 hours, 3 to 6 and 6 hours. Your mortality, your survival goes dramatically down. If I want to remember one thing from today, is what I do when I'm set up against the septic patient. I ask the nurse, I say, please have eye contact with me, stop doing everything else what you do, give these patients 2 grams of something starting with letter C, whether it's cefotaxime, ciprofloxacin, whatever it is, give it within next 10 minutes. Because as you delay, this is what's happened. This is mortality increasing with a lapse of time from dropping blood pressure, becoming hypotensive. The patient is now 5 hours hypotensive without antibiotics, 6 hours hypotensive without antibiotics, 9 hours. And if there is one slide I want you to remember from this presentation, it's the last one. Thank you.